So Stu, you raised some really interesting points there about, we now have a sense of what we mean by off, but what causes off? So Raj, you want to address that?
So, we talk about off that it may have central issues. The patients are losing dopaminergic neurons as the disease is progressing. So initially, early in the disease course, when they take levodopa, it goes to the brain and is converted to dopamine, there is still enough dopaminergic neurons that can store it and still release it physiologically. As the disease progresses, this buffering capacity, so to speak, is lost. So what happens is they take the levodopa, convert it to dopamine, and release it at the postsynaptic receptors. So the benefit of each dose of levodopa kind of mirrors the half-life of levodopa, which is 90 minutes. And in advanced disease, some patients could pretty much be taking a drug about every 90 minutes to 120 minutes because of the central mechanisms that are at play. And we are also now talking about the adenosine receptors, which act on the indirect pathway. And with Parkinson's, as the disease advances, there's an increase in A2A receptors. And we feel that's another mechanism by which the indirect pathway is affected, and it acts as a braking or a slowing down system. And that's another mechanism that also comes into play as far as the mechanism of motor fluctuations are concerned.
So A2A receptors that are sitting on this indirect system, which is the brake in Parkinson's, right? It worsens motor activity, and now you have agonism of that brake through the A2A system. So this is something that, really is coming to the forefront a little bit in Parkinson's disease as another potential central effect of
Right.
of
Using an
disease.
A2A antagonist, we definitely can, so to speak, release that brake.
And not just adenosine, but glutamate receptors as well are upregulated in
Hey,
both the direct
how
and
about
indirect.
deep brain stimulation is also working on these downstream systems. So managing Parkinson's is more than just replacing dopamine stimulation, or at least beyond the first few years or even months of therapy. So there's more to treating Parkinson's than just going after a deficient dopamine synthesis. But I think it's also worth bringing back the notion that should we be using all these therapies together in the same patient? Is there evidence for that? And I think more and more evidence is emerging that polypharmacy or multi-target therapy of Parkinson's makes sense.
When I'm educating patients as to why they might need to have to take so many pills, because they're on so many other pills to begin with, I often tell them that you can affect the levels of dopaminergic tone through multiple mechanisms, and oftentimes it's complementing the mechanisms in different ways. And there's a strategy because of the complement of how they all work together, but there's also the strategy of not having to maximize one particular medication to its fullest so that you can avoid side effect profiles. So I think that there is, practically speaking, a lot to be said for complementary mechanisms of action.